Good morning and welcome to this webinar about the genetics of celiac disease. My name is Clarissa Miel and I will be your presenter today. This webinar is offered by Genyca, a laboratory specializing in molecular biology, including predictive genetics. We must say that we are a reference laboratory of celiac disease in Spain. Our presentation today will include the following points. We'll start introducing predictive genetics and how it can help us with the day-by-day with patients. After which, we'll focus on celiac disease and end in with a description of the action protocol, how simple is the saliva sampling procedure, and the different administrative and practical issues of a genetic test request. During this speech, you can write your questions in the chat box that you are going to see in the control panel located at the right of your screen. We'll answer the questions also in the space dedicated to the chat. If you have more questions, you can send us by email to clarissa@genyca.es. And at the end of the presentation, I will remind you our special promotion of the month. So, we'll start explaining what is predictive genetics. This is the medicine branch allowing determination of the probability to develop certain diseases during adulthood. Its main objective is to apply preventive measures in order to avoid the disease, but if the disease cannot be avoided, at least delay its onset or lessen its symptoms. We must highlight that every method of predicting future diseases is based on genetics, and that is what I'm going to present today. The objective then is to know the patient's genetic background through a genetic test, and this is going to allow us to change the environment. In this case, the environmental factor is exposure to gluten in order to prevent the disease. This can be applied to all multifactorial diseases in adulthood: obesity, diabetes, cancer, celiac disease, cardiovascular disease, Alzheimer. We will now focus on celiac disease. And we are going to start with one of the many definitions we can find for this disease. So, this is a multisystemic disease, immunologically induced, with genetic base and permanent character. Celiac disease is long to diagnose. It takes an average of 10 years to diagnose a celiac disease because symptoms are very different and very diverse. So we'll go now through the different symptoms so we can all easily understand the difficulty of the diagnosis. I'm presenting here in three groups: the digestive symptoms, extra-digestive, and also when there's no symptoms. In the first group, we are going to find the classical symptoms that are very frequent in children but infrequent in adults, only at 14%. And these are going to include the chronic or recurrent diarrhea, abdominal distension, anorexia, weight loss, asthenia. Second group is a little bit more complicated. They are the extra-digestive symptoms, which are very frequent in adults. That's why the diagnostic is difficult. These are going to include joint and bone pain, tiredness, infertility, abortions, depression, anxiety, ataxia, fractures without trauma, early menopause, paresthesia, dermatitis, hair loss, aphthia, and amelohypoplasia. This is why the average to diagnose takes 10 years. And then we have a third group, as when we have symptomatic patients, no symptoms, no negative antibody clinic. So in this case, the basis of the diagnostic are the demonstration of intestinal alterations and the genetic study. Now I'm going to present you some figures. So in general population, celiac disease will affect 100%. So as much as 80% of celiac people are not diagnosed. But these figures are different for people with positive genetics, increasing to 1 in 30, or if you prefer, 3 in 100, 3%. When in addition the individual has first-degree relatives affected, the risk increases even more, and we go up to 1 in 10 people. It is therefore very important to make a genetic study to know if the patient is considered to be in the general population or if the patient has a higher possibility to develop the disease. Now I'm going to explain you the etiology of celiac disease. Celiac disease causes are quite complex. It is a disease with a very important immunologic component. Celiac disease is strongly associated with the presence of antibodies against gluten and similar proteins, and also autoantibodies against connective tissue components, mainly against transglutaminase 2. So these various antibodies are antigliadins, anti-endomysium, anti-transglutaminase, and anti-synthetic peptide. And all of them develop the inflammatory cascade involving all the symptoms of celiac disease. And this immunologic component we know is perfectly described and known. Second component, genetic. Different familial segregation studies suggest an important genetic predisposition to celiac disease, characterized by a prevalence that is different in monozygotic and dizygotic twins and first-degree relatives. Studies on monozygotic twins that share 100% of their genes show a very high concordance rate, between 70 and 100%. So this means that between 70 and 100% of the causes of celiac disease match in this kind of twins. Between dizygotic twins, the concordance rate is low, 20%. And between first-degree relatives is between 8 and 18%. What means that the genetic component provides a very important role in the development of the pathology, as twins have a very high concordance, but the disease cannot be only due to this, because in that case siblings would develop the disease in a much more striking way, which is not the case. So this means that there's also a very important environmental component, which in our case, this is the exposure to gluten. The incomplete correlation between couples of monozygotic twins confirms the environmental component of the pathogenesis of the disease. So in some cases, a close monitoring would be necessary to ensure that the disease will not develop in the future. But in all cases, this is a multifactorial etiology, alteration of a multifactorial etiology with a very important genetic component. So now what we're going to do is focus on the genetic component, where we have HLA genes involved in the development of celiac disease and non-HLA genes. And we'll start first with the non-HLA genes because they are a little bit easier to determine. In this graphic, I want to show you the heterogeneity of the non-HLA genes associated with celiac disease. You will see there in the center we have these bubbles with the name of the genes inside with different sizes. So there's a lot of heterogeneity. They are genes affecting the neurologic system, hematologic genes, metabolic genes, cancer genes, and most of all, genes associated with immune response. So all the genes you see here in the middle of the circle have been described in bibliographical references associated with celiac disease, and the size of the label in which the gene names are written is directly proportional to the number of associations or bibliographic references in which an association with celiac disease is proven. So that is, there are genes more strongly associated than others. The bigger the label is, the stronger association. The smaller, the less important association has been found until now. But my objective today is that you see the complexity of the genetic load that this disease may develop. It is not a monogenic disease in which if there's one mutation, the patient has the disease. In this case, there's a much more complex etiology. So these genes we have just seen, they are being investigated, the non-HLA genes. In the coming years, we hope we'll see the product of the investigations and hoping that they will bring more light to the disease. What we can do today and what we know better are the HLA genes that were discovered first, and they have more association studies done. So we'll go to them now. So let's have a look at the gene location. HLA genes are located on chromosome 6. This is the chromosome 6, and there are several groups of HLA genes. The ones we are going to see right now, those associated with celiac disease, are DQA1 and DQB1, which are class 2 genes. And now we see down here, genes DQA1 and DQB1 in the chromosome 6. These genes are responsible of the presentation of antigen in T cells. When these genes have any of the markers associated with celiac disease, the presentation of the antigen does not happen in the right way and leads to the inflammation cascade and intestinal symptoms that celiac patients present. From the genetic point of view, the protein synthesized by these genes has a component that is located outside the cell membrane and one part that is located inside the membrane. And as we see here, we have two chains, the alpha chain on the left and the beta chain on the right. And each one is synthesized by a gene. The alpha gene is synthesized by the gene HLA-DQA1 and the beta chain by the gene HLA-DQB1. We analyze both DQA1 and DQB1 because it is the combination of both that is giving us some markers or the others. Let me give you an example so you can understand more clearly. When on DQA1 we have, this is the DQA1, we have alleles 0501, and on DQB1 we have alleles 0201. This combination of DQA1 0501 and DQB1 0201, this combination on only this one is what we call the DQ2, HLA-DQ2. And we call it DQ2 because it's just a way of simplifying. And this is the one of the haplotypes associated with celiac disease. Let's go and see another one. The other haplotype associated with celiac disease is the one where we have in DQA1 the alleles 03 and 01, and in DQB we have alleles 0302. And this combination of 0301 and 0302 is the one that gives the haplotype HLA-DQ8, what we call DQ8. And DQ2 and DQ8 are the two markers that have been associated more times with celiac disease and the more widely demonstrated. So, these two are very important, but there are more. We have simplified a lot in this graphic, so you can see from where we take DQ2 and DQ8, but in reality, DQ8 is always allele 03, and no matter what the two new figures are, when there's 03, it's always DQ8. So, each of these markers gives a higher or a lower predisposition to develop celiac disease. For example, in the first line, if we have DQ2 in cis position, the risk is high or even very high. On the second line, we're going to see DQ2 in trans, and if it's in trans, it's a moderate risk. And DQ8 is a moderate risk too, but there are two haplotypes that are not always detected because not all the labs, not all the laboratories allow detecting these two, which is detecting 02 in DKA1 or 02 in DQP1. These two alleles are called half DQ2, and not all laboratories are going to detect them. So I would recommend you, whenever choosing a lab, always ensure that they are capable to detect the half DQ2, because the half DQ2 has a risk. We see here that is moderate or low, but it is a risk. It is still a risk. So patients that have this genotype cannot exclude celiac disease. We need all the data from each patient. Here in this graphic, it is the same as last slide, the previous slide, just represented in a different way. So why is it important to detect DQ2, DQ8, and half DQ2? Because in non-celiac population, what we call normal population or healthy population, 30% of the individuals have DQ2 or DQ8. The 70% does not present it, but there is an important percentage of population that have DQ2 or DQ8. They have it, and this does not mean that they will develop celiac disease. They are carriers of the genotype. So you're going to say, so why? If we have healthy population, non-celiac population, some population that have that carry these two haplotypes, why are we doing the test? Because we go now to check what happens in celiac population. All celiac population, the 100%, have DQ2 or DQ8 or half DQ2. And we see that DQ2 is much more frequent, is present in 95% of the patients, while DQ2 is present only in 5% of patients. But as a set of them too, all celiac patients present them, DQ2 or DQ8. What means that if we make the genetic study to a person that does not know yet if he has celiac disease because he can be a relative of a celiac patient or someone that has not yet been diagnosed, and we find that he does not have DQ2 or DQ8, then we have to place him in a part of the chart corresponding to the healthy population that does not have DQ2 or DQ8. And in this case, the disease can be ruled out. We're going to put him in this part of the population. And so these two markers have an excellent negative predictive value for celiac disease. If we make the genetic study to the patient and we find out that he has DQ2 or DQ8, we don't know where to place him in the chart. If in a group of patients that have this genotype, or if in a group of healthy control that have the genotype but will not develop the disease. So we don't know when he has DQ2 or DQ8 if he's going to develop the disease or not. But we know that he has more possibilities to develop it. That is, the main objective of this study is to exclude celiac disease in those patients where there is doubt, or for celiac people that have relatives, celiac relatives affected, and want to be sure that they will not develop celiac disease if the results are negative. This test, I repeat, has an excellent negative predictive value. So, what are the objectives of this genetic testing for a patient? First of all, support the diagnosis. Identify patients susceptible to celiac disease to know if they have possibility of developing the disease or not. The second is very interesting for families that have already affected children, and it is to discard celiac disease in people with no risk, even if they have affected relatives. If they haven't inherited these markers, they will not develop the disease, and this information is going to give them serenity. We will see a clinical case at the end of the presentation. The third objective is again support of diagnosis. It's going to be preventing associated pathologies in a patient. Being able to diagnose as early as possible that a person has celiac disease can facilitate that the individual is well nourished, or is not going to develop Crohn's disease, or some type of lymphomas. That is, it is very important to proceed to an early diagnosis. And the fourth is to make family studies, because the disease having a strong genetic component, we can know the risk and susceptibility that first-degree relatives of a celiac patient have. When is the study recommended? What are the inclusion criteria to be considered in the test? It is recommended for patients that have uncertain diagnosis, that is, to make a differential diagnostic. Those patients that don't have clear symptoms, or when the symptoms can bring confusion in case there are several different pathologies, the existence of celiac disease can be excluded. If there's no presence of DQ2, DQ8 and half DQ2, the disease is excluded in 99% of patients. Then it can also serve as support of the diagnosis. If the patient has symptoms that are different from the classical diarrhea, which are 50% of the cases, or symptoms that are not digestive, in this case, a positive result can support the diagnostic and is going to bring more information to the specialist so he can make a better diagnostic without losing time. We saw in the first slides that the average to diagnose a celiac disease is 10 years. Another inclusion criteria will be family studies. When there is a celiac patient already diagnosed in the family, it is recommended to make the genetic study to all relatives, at least on first degree, parents, siblings, children, in order to identify the patients with risk to suffer celiac disease. Patients with risk may never develop the disease, but maybe if they are developing the disease with symptoms so different from the classical ones, or from the symptoms the family has, or subclinical symptoms, it is possible that the disease is not being identified. So the sooner it is diagnosed, the better, to avoid more serious complications. The third inclusion criteria will be asymptomatic patients that have a high risk because they present any of the diseases linked to celiac disease, such as diabetes, autoimmune thyroiditis, patients with Down syndrome, or Turner syndrome, or Williams syndrome. The objective is to early diagnose and prevent serious complications. And really not only in these patients, but in reality all patients with autoimmune diseases like arthritis, osteoarthritis, they should always make the genetic test of celiac disease in case they have developed this disease. We have a lot of patients coming from rheumatologists, and we will have another clinical case at the end of this presentation. And what do we do with the results? Once we have identified the haplotypes associated with celiac disease in the patient, so DQ2, half DQ2, or DQ8, the patient has a risk to develop celiac disease. If the individual is not a patient but a first-degree relative, or if he belongs to a risk group and markers have been identified, this result justifies a monitoring, and the individual should make periodical antibody analytics to verify if the disease has developed or if symptoms have manifested. In the case the patient has inconclusive clinics or unclear, confusing clinical data, and markers associated with celiac disease are identified, these genetic markers can confirm the diagnostic. According to the criteria of the European Association for Pediatric Gastroenterology, Hepatology and Nutrition, if the patient has positive genetics and also has symptoms, there are times where it's not necessary to perform a biopsy to see the intestinal villi, because the genetic test would confirm the diagnosis. So, in some cases, we can avoid a biopsy to the patient thanks to the genetic test. To better understand, I'm going to show here the usual steps to diagnose celiac disease. So, normally when a person has a celiac relative, the first thing they are going to do is an antibody study from a blood sample. But this antibody study, in the vast majority of cases, may be negative. So it is recommended to repeat it and repeat it and repeat it periodically, usually every 2 years. When the antibody blood test is repeated and it gets positive, we have it here. When this happens, a biopsy has to be performed to confirm the diagnostic. And if the biopsy is positive, the diagnostic will be that he has celiac disease. This is the way to diagnose a person with celiac disease. And in these cases, usually when this happens, is because the individual has positive genetics, positive HLA marker. But what would happen if the person has negative HLA markers, no risk markers for celiac disease? That means that there is no need of monitoring, no need of making clinical analysis every 2 years. We have simply excluded the pathology. So the situation is much more comfortable for the patient. Knowing this information, he's avoiding all subsequent studies. And now I'm going to share with you 2 clinical cases. These clinical cases are quite striking, but not striking for the clinical case itself, but because of the number of cases we receive. These are the 2 main profiles of patients we receive at the lab. So the first clinical case is an infant 4 months old that had 2 older brothers affected, one diagnosed at 10 months and the other at 30 months old. This baby, the parents have not introduced yet gluten in his diet. So we perform a genetic test from a buccal oral mucosa sample, which is painless, ideal for a baby, ideal for everybody, I must say. And we see that there are no markers for celiac disease. He has DQ5 and DQ6. He does not present the celiac risk haplotypes. So this means that the patient does not present celiac disease risk. So the medical advice is that the possibility to develop celiac disease is excluded. No more distress for the parents. Now they know they can introduce gluten in the baby's diet at any moment, not like with the older brothers. And also there's no need of future clinical follow-up. And there will be no symptoms because the disease has been discarded. This is a typical case we receive at the lab every week and not once, many times per week. And now I'm going to show you the second clinical case that we also receive a lot. This case is a lady, 50 years old. She's a grandmother. This is the case of first-degree relatives of the celiac patients. This lady had difficult digestion since her childhood, and now she's developing rheumatoid arthritis. And recently, her 2-year-old granddaughter has been diagnosed with celiac disease. It is easier to diagnose in children because they present the classical symptoms. And the mother of the girl, which is this grandmother's daughter, also presents symptoms, and there's suspicion of celiac disease for her too. But as the grandmother had more symptoms, including immunological affections, she came as to make the test. So we performed the test, and we found out that she had DQ2 and DQ7, what means that she has a high risk to develop celiac disease. It is possible that this lady, because we have seen she started with symptoms, intestinal symptoms when she was a child, it is possible that she is an undiagnosed celiac. So now she must follow a strict gluten-free diet, and after 3 weeks, only after 3 weeks, the patient started to feel digestive improvements, and after a few months, her joint pain has even lessened and her life quality has improved. If this grandmother had been diagnosed when she was a child or a young woman, she would probably had a much better quality of life. So now, once we have done a review of the celiac disease and genetic characteristics, we are going to show you the action protocol. How are these genetic tests done? The first thing I want to tell you is that sampling is very easy, very simple. It is done from cells of the oral mucosa. We often call it saliva sample because we want the patient and the doctors to understand that the sampling will not hurt. But what we're really taking are cells in the inner part of the cheek. We use a sterile swab, it's a sterile cotton that comes in a protection case to take the sample. You see here the protection. We are going to open it, breaking the security seal, and especially avoiding to touch the cotton swab. Sometimes we can put sterile gloves, but it's not necessary if we don't touch the cotton swab where the cells are going to go. So 2 swabs are needed, 2 swabs per patient. We're going to use 1 swab for each of the interior of our cheeks. We insert the cotton swab in the mouth and we rub up and down, the interior of the cheek area during 1 minute, and we press firmly. Because what we want is to get the cells. We don't want the cotton swab soaked in saliva because we will have very few cells from the cheeks. We don't want it soaked in saliva. We want the cells. And once we have taken the sample, we dry it a little bit just in the air, and we put it back into the protection case. Then we clearly write the name on the cover, the outside of this protection case. And this is to be sent to the lab, Genyca in this case, at room temperature. No special transport conditions are required. In a package or envelope, it's that simple. Patients don't require special preparation, just they don't need to be fasting, but please try to make them understand that they need a clean mouth. So 1 hour before the sampling, do not eat, do not drink, do not smoke, don't wash the mouth and teeth, no chewing gum, 1 hour before. This is the only preparation. While the patient is with especially the doctor, they have to fill the request form and informed consent. Informed consent is at the end of the request form for the test, and the patient must sign it. It's in page 2. And this scheme is representing, summarizing how this is going to happen. The patient goes in a first consultation to his physician, or he goes to an association. They take the sample. The patient can take the sample at home too. They take the sample, they fill in the form, they sign the informed consent. They send that in an envelope to Genyca, and then Genyca, 2 weeks later, is going to send to the physician or the association the results by email with a protection code. And then the physician is going in a second consultation to explain the results to the patient. When this is an association or a lab, we can be outsourcing to a lab. We can send it to a lab. They can send a package with more than the sample of one patient. It can be grouped. The important thing is that the data is clear on the protective case in the papers too. So summarizing, what is undergoing a genetic test with Genyca? Easy. Saliva sample or a mucosa sample, avoiding blood sample extractions. Convenient because the sampling can be done at home or can be done at the physician consultation. So the patient is going to avoid extra trips to the lab. Unique. Genetic results are valid for life. No need to repeat it. Innovative because this is a new tool at the forefront of technology. And familial results allow preventing associated diseases in relatives. And because this was the month of the celiac disease, in Europe we usually celebrate it on the 16th of May, and Latin America is going to be the 5th of May. We thought it was the right month, the right opportunity to make this presentation about celiac disease, to create awareness, and also propose a promotion. So for all those people that have participated to the webinar, if they send us 10 samples for celiac disease during the month of May, the number 11 will be free of charge. If they send 20, but the 2 following, the 21, 22, will be free of charge. So now I just would like to thank you very much for your attention. I had my colleague Teresa answering questions during the webinar. If you have more questions now, you can still write them in the chat box. If you have more questions, you can also send them by email to this address, and we will answer all of them. So I hope, are there any more questions? I don't see questions right now. Let me see. I just see that someone missed the first slides. If you have missed some slides, I can just send me an email and I can send you the registration of this presentation, or I can make you a summary of the first slides. In the first slides, I was speaking about predictive medicine and how it can help the patient. So I think there are no more questions. I'm going to say thank you very much for your attention. Hope this has been helpful for you, and just send me any questions you might have, and hope someone is going to try to try the promotion, or just hope we will get some news from you. Thank you very much, and I will keep you informed if we have any other webinars or any other promotions. Thank you, and goodbye.